Well, hello everyone. Welcome to the Voice of Lupus Foundation. This morning, we are discussing common questions in lupus. Now, over the weekend, we commemorated on Saturday World
Well, hello
Lupus Day.
everyone. Welcome to the Voice of Lupus Foundation.
This morning, we are discussing common questions. I do apologize. There's a little technical issue, so I'm just forgive me. So just bear with me here. So as I was saying, on Saturday, we commemorated World Lupus Day, and we hosted a very significant event, a milestone event, where we hosted our virtual conference and health fair, where we featured many experts in the medical field, as well as mental health, nutrition. We dealt with ophthalmology. We dealt with so many aspects of what living with lupus is like. One of the segments that we were not able to delve into because of time, as you know, the event started at 2, but we did not finish, not until maybe close to 9 o'clock, because of the wealth of information and the amount of engagement there was. So I wanted to just make sure that I did not rob patients of questions that they would have submitted and they sought answers. So facilitating the answers would be Dr. David King, who is a consultant in internal medicine and has served in the Northwest Regional Health Authority for the past 14 years. Dr. King obtained his MBBS and DM internal medicine with the University of the West Indies and has worked at the Port of Spain General Hospital and subsequently the St. James Medical Complex. Now, during his tenure, he developed a keen interest in treating patients with musculoskeletal disorders and autoimmune conditions such as lupus and rheumatoid arthritis. He is also an associate lecturer with the University of the West Indies, where he helps mentor medical students in the field of internal medicine and rheumatology. Now, Dr. King is currently attached to the Physical Medicine and Rehabilitation Department at the St. James Medical Complex. He oversees the rheumatology clinic and a special infusion clinic where patients receive intravenous treatment for their various rheumatological conditions. Now, Dr. King has a personal and vested interest in helping those with lupus and other autoimmune conditions. And of course, he remains dedicated to the cause in fighting lupus by providing tailored and holistic care plans in a safe and comfortable environment. Dr. King, as I said, he possesses an MBBS, DM internal medicine, and a diploma in rheumatology. So we would have fielded your questions, and of course, Dr. King would have provided the necessary response to your questions. So we want to delve into some of those questions. I know it's quite a lot. I believe it's like about 17, 18 questions around there. So the first question, are there any recent medical advances pertaining to diagnosis or treatment of lupus? Well, treatment of lupus requires the administration of medications to modulate the immune response, thereby reducing the severity of lupus. Now, newer treatment options of autoimmune conditions such as lupus involve the use of biologic drug therapy, which are designed in a way to target specific inflammatory pathways, modules, or autoreactive immune cells, thereby reducing the risk of flares and controlling lupus. Now, the diagnosis of lupus is still very much dependent on the European League Against Rheumatism and American College of Rheumatology, EULAR and ACR classifications, whereby a combination of symptoms, clinical signs, and blood tests. And over the years, you would have heard the Voice of Lupus Foundation lobbying about that. You can't just walk into a health center here in Trinidad and Tobago and say, okay, can you stick my finger and test me for lupus, or can you just do a blood test? It's a barrage of testings. And of course, as you heard, there are classifications where there has to be a combining of symptoms, clinical signs, and blood tests in order to get that confirmed diagnosis. And usually A score of 10 points or more on the scoring system suggests a diagnosis of lupus. With this relatively new criteria system, the accuracy of the diagnosis of lupus has quietly improved compared to other scoring systems previously used. Okay, so I hope that helped. Now, the second question, is there a headway toward finding a cure for lupus? Let's understand what lupus is. Lupus is an autoimmune condition that is chronic, and therefore strategies around managing lupus include suppressing the immune system sufficiently to limit inflammation and hence reducing flares and control the disease process. Similarly to managing someone with diabetes or hypertension, there is no cure for lupus, but it can be managed in the long term to allow for a near normal life. Number three, what are biologics, and can they be considered as a local treatment option for patients? Well, let's break it down. Now, I'm not a doctor and I'm not a medical expert here, but I'm simply facilitating this conversation. So, a biological is a medication produced from living sources such as microorganisms, animals, or human cells, and used to target specific components, proteins, or certain inflammatory pathways of the immune system. This basically means that they are grown or harvested inside different types of living cells under certain strict and specific conditions in designated areas or laboratories. As a result, once the desired drug is extracted, it must also be stored under the right light and temperature in order to maintain its integrity. And that's what biologic means, right? So biologic treatments for patients with autoimmune conditions are available throughout the public health system. Number four, how does lupus affect women approaching menopause? In the pathogenesis of lupus, various hormones such as estrogen and prolactin are implicated. So, as one approaches menopause, the varying levels of hormones may possibly improve or worsen lupus. In an effort to tackle this unique situation, treatment with hormone replacement therapy, whilst ensuring that flares adequately managed, and that is really the appropriate objective. And I know that from a history of treating and dealing and seeing so many other patients, I have noticed that there are many patients who talk about the worsening of their symptoms or they flare around the time of where their menstrual cycle is due. Now, what symptoms should women with lupus monitor during pre-menopause or even menopause? Well, joint pains, fatigue, mood changes, sleep issues, and cognitive issues such as memory loss. These can occur in both lupus and menopause or premenopause. However, some distinguishing symptoms to suggest lupus-related flares include fever, oral ulcers, skin rashes, shortness of breath, and joint swelling. Further to this, a clinical evaluation with urine and blood tests can help confirm the possibility of flare or premenopausal or menopausal symptoms. Number six, pregnancy and lupus nephritis. Well, this is a big one. The situation requires a multidisciplinary team involving rheumatology, nephrology, and obstetrics. These teams must come together for the optimal outcome. Planning for the pregnancy includes the following strategies. Number one, pre-pregnancy counseling regarding the risks to the mother and the fetus, since there's a high chance of a severe flare that can go up during pregnancy. Number two, the use of folic acid for at least 3 to 6 months prior to the intended date of conception. Ideally, barrier protection contraception to prevent getting pregnant during the above time period. Maximizing treatment options for lupus that would be safe even during the pregnancy in order to achieve low disease activity or remission. Now, once the lowest level of disease activity is achieved, then medications can potentially be weaned to the lowest dose possible. We must monitor blood tests such as kidney functions, urine tests, complement C and 4 levels, electrolyte sedimentation rate, that's the ESR, C-reactive protein, complete blood count, liver function test, and monitoring vitals such as blood pressure, the pulse, and of course, blood sugar. Additionally, testing for AS syndrome, that is the antiphospholipid syndrome. Forgive me, I tripped over that word, but it's a very long one, so it's short for AS. Ideally prior to getting pregnant, and treat accordingly, and this may be a reason for miscarriages. We must consider the use of low-dose aspirin within the first 3 months of getting pregnant, and of course, closely following up with the nephrologist, the nephrology team, with an aim to possibly repeat the kidney biopsy before getting pregnant. What else should we be doing? Well, at least monthly follow-ups with the rheumatology team once being pregnant. What else? We have managing fatigue and lupus. How can we manage fatigue? That's a million-dollar question because it's a very difficult question because no two lupus patients are identical. So fatigue and lupus can be due to a number of factors, inclusive low blood count, anxiety, depression, lack of sleep, stresses of life due to limitations in activities of daily living, other medical problems, or even side effects of some of those medications used to treat lupus. In an effort to deal with fatigue, the following strategies can be implemented. Number 1, stress management. Number 2, adequate hydration, exercise, and a well-balanced diet. Managing lupus to get the condition to its lowest levels of disease activity and reduce flares. Improving blood count with iron supplements. Treating comorbidities, including anxiety, depression, appropriately with the relevant medication. And of course, having support, whether it's through the Voice of Lupus Foundation, having support from family and friends, community makes the difference. Number 8, coping mechanisms whilst tapering off steroids. One of the main objectives in treating patients with lupus is to have them on the lowest dose of medication. Steroids tend to be initiated early in the treatment of lupus and even during flares. However, since lupus is chronic and long-term, medications are required, and drugs that do not have any steroid components is preferred to limit the plethora of side effects that can occur with the use of long-term steroids. Now, if a patient has frequent or severe flares whilst attempting to be weaned off steroids, we can use one or more steroid-sparing drugs such as Imuran, that's azathioprine, hydroxychloroquine, also known as Plaquenil, and Celsep. Now, other factors to look at is the social situations which they are experiencing. So many times certain stresses, whether at home or work, if addressed, can lead to a reduction of flares. Lastly, any anxiety or depression can aggravate the lupus flare, and relevant medications and counseling can help. Number 9, standard test for lupus and its accuracy. Well, diagnosing lupus requires a mix of symptoms, signs, and blood tests and kidney biopsy. However, common blood tests that are normally done include antibody tests such as the anti-nuclear antibody, which is called an ANA, anti-Smith antibody, it's called anti-SM, and markers of disease activity such as complement 3, C3, complement 4, known as C4. The ANA is commonly tested and at times used as a screening tool when persons present with vague or non-specific symptoms, pains inclusive of joint pains. Now, when combined with various clinical features, a positive ANA test is highly suggestive of a diagnosis of lupus. Now, regarding the anti-Smith antibodies and the double-strand DNA antibody tests, that is, there are more than 90% specific for lupus. I'll repeat that again. Regarding the SM and the dsDNA antibody tests. They are more than 90% specific for lupus. What this simply means is that if these tests are positive and there are other clinical criteria supporting a diagnosis of lupus, then most likely you have lupus. Number 10, lupus symptoms, lupus-like symptoms, but negative tests. Oh my gosh, we've gotten that so many times here at the Voice of Lupus Foundation, where persons would have all the symptoms, but their blood work is negative. Statistically, about 2% of patients with lupus-like symptoms have a negative ANA test. The aim would be to similarly manage their symptoms. Why the ANA could be negative? Well, maybe explained by the technique that the laboratory may use to test the ANA, or possibility that the body is producing the autoantibody, but not enough to allow for the detection on the blood tests. Additionally, one may need to look at other less commonly tested antibodies, autoantibodies, which could cue in the diagnosis of lupus or other autoimmune conditions, and even something called mixed connective tissue disease or undifferentiated connective tissue disease. Discoid lupus and awareness. Well, depending on the severity of the skin lesions, discoid lupus may not be very noticeable and can be quite conspicuous. So once there is a diagnosis of discoid lupus, monitoring of the progression of the skin lesions and any other systemic features is very much important. So at that point, when systemic symptoms are occurring, the appropriate medication would be initiated. The important fact is that once you have any form of lupus, you must be monitored by a healthcare professional, dermatologist, and rheumatologist. Number 12, lupus and chronic obstructive pulmonary disease, diabetes. Now, some useful supplements would include vitamin D, since sunlight exposure is usually limited for those living with lupus. Vitamin B12, calcium supplements to help with bone health, and other micronutrients such as magnesium, zinc, fish oil such as omega-3. However, there's no magic dietary supplement for managing lupus with other comorbidities. The main aim in this scenario is to ensure adequate control of all the conditions. Now, the caveat to this is that both lupus and COPD may require steroid therapy for control, which inadvertently worsens diabetic control. There's something called steroid-induced diabetes. Now, this is about balancing things with mitigating stress, graded physical exercise, a well-balanced diet, whilst minimizing control of lupus with minimal to no steroids. Well, how often should organs be monitored? I know many of you are very panicky about that. Okay, I've got systemic lupus. Oh my God, does that mean that all my organs are going to shut down? Well, here's what's happening. It all depends on what new symptom is occurring. Generally, lupus patients can be monitored every 3 months, where a complete blood count, liver function test, renal function test, C3 and C4, ESR, CRP, urine analysis, 24-hour urine protein assessments are done. Imaging using X-rays, ultrasounds, and computerized tomography, that's CT scans, may be necessary depending on which organ or organs may be involved. So I know I've said a mouthful there. There are some other questions, so let's get on with it. When should I consider seeing a nephrologist or another specialist? As we know, lupus can affect any organ system, and depending on the presenting symptoms and signs, the patients would be referred accordingly. Now, since lupus nephritis is one of the bigger challenges and concerns, referring to a nephrologist usually occurs when there is a deterioration of kidney function. This is measured by a creatinine blood test and a urine test, where the amount of protein detected is more than 500 milligrams in a given 24-hour period. At this point, the nephrologist would initiate relevant management strategies to minimize progression of the kidney damage. Lifestyle, mental health, and nutrition impact on lupus. Well, these factors can have a profound effect on the control of lupus flares. The social module in systemic lupus erythematosus suggests that lupus is influenced by a complex interplay of biological, psychological, and social factor causes. What this means is that lupus control or risk of further flares are related to lifestyle factors such as exercise, diet, support systems in place, stress-related factors, and any anxiety or depression that occurs. Helping managing these factors and the expectations of a patient can help prepare them for coping and living with lupus. There are a plethora of resources available via the clinic and the Voice of Lupus Foundation for patients needing help to cope with lupus. Lupus flare or medication side effects. It would depend on the drug, but differentiating factors would include timing and triggers. Medication side effects occur soon after initiating the drug and is due directly to the drug, whereas as a flare tends to be over a more protracted course of time and may be triggered by sunlight, stress, and some other illness. Are my current medications best suited for long-term management? Well, in many cases, there may be medications used in short term and others for the long term. Consideration of which category of medication would be all dependent upon your condition, the severity, and whether you're having a flare, and most importantly, your informed decision on what is best suited for you. So consulting with your usual physician, rheumatologist, etc., would be the best way forward in determining what is the best long-term management plan. So overall, lupus is not a death sentence. It is a chronic illness that requires managing symptoms and flares as they continue and they come. Patients are not alone in this journey because of the doctors, the family members, the friends, and support groups that are accessible, like the Voice of Lupus Foundation. So on behalf of Dr. David King, he says thank you for the opportunity to answer these questions from your network of patients. So I hope this has helped each one of you. Thank you for listening. I'm just going to end the live